Okay, so you're asking me a secret question. What's the question?
Okay, if you're taking medication for dementia.
For dementia. Yeah.
If you increase it, that's the core in the brain, right?
Mm-hmm.
Will it be increased from somewhere else, or is there?
Okay, so the question is, if you want to treat Alzheimer's dementia, and you give them acetylcholine agonist to increase acetylcholine, in Alzheimer, you could increase acetylcholine. So would it increase acetylcholine concentration in other parts of the body? Possibly. But you give medication that are most likely permeable to the brain selectively, so that the rest of the body, like your heart, GI, are not affected so much. But nonetheless, yeah, depending on the dosage. Okay, Isba, you had a question?
Yeah, but it was from like pancreatic.
Doesn't matter. Don't matter. You can ask me a question about 3 years ago. It's fine.
You were saying in acute pancreatitis there's not supposed to be lipase and amylase, right?
In acute, there should be
In the
lipase.
blood.
There should be in blood.
I know, but normally you shouldn't find lipase and amylase in the blood, right?
Normally, yes.
So whenever you said that, in chronic pancreatitis, what is normal levels of lipase and amylase if it's not supposed to be there?
No, that's not true. If I understood you correctly, this is what I understand. You're telling me that because early in the morning I can hear things weird, right? You're saying that normally we should not find much of lipase, pancreatic lipase. We're not talking about any other lipase. In blood, you should not normally find pancreatic, lipase, and amylase. That's true. Now, in chronic pancreatitis, the pancreatic cells are destroyed. So there's less pancreatic enzymes to begin with. There's less likely chance of these enzymes to spread into blood. So when you find in blood amylase and lipase, you should be thinking of acute pancreatitis, not chronic. In chronic, the cells are destroyed, in a long period of time. So there's not enough cells, pancreatic acinar cells, to produce the enzymes. But in acute, the cells just recently ruptured, just now. Obviously, the enzyme will be where? In blood. In chronic, you cannot make enzymes. So the difference is that in chronic, either the enzyme is normal or decreased. But in blood, it's almost always decreased. Yeah. So another way to differentiate, between chronic and acute is you measure the enzyme concentration where? In duodenum. In duodenum for chronic pancreatitis, the enzyme will be less. Acute, you don't even have to go that far. You have to treat it, make sure you take care of it. Okay, any other question? No? Okay. Large intestine. Diverticulosis, I don't know if you heard of this. And Hirschsprung disease. That's 2. Anything else? Let's say angiodysplasia. Okay. Now I'm thinking, I don't think I discussed congenital disease of small intestine, so I'll come back to that. Let's just remove this one, and I'll discuss right after this. Maybe anal fissure. I don't know. You guys can look. What am I missing? And large intestine diseases. Okay. Diverticuli. You know what diverticuli means. Outpouching, ballooning, dilatation of intestinal mucosa, submucosal layers. It can expand and even go into the muscularis and serosa, but usually they're just mucosa, submucosa. Okay. So if mucosa extends into the muscularis and serosa, then it's called diverticulum. But as I said, depending on how far they extend, sometimes they can even include all layers. The extension, the diverticula can include all layers. Okay. So that's one thing. Huh? Possibly, but not. So diverticulosis, simply you have, now when you use the term osis, it means a lot of them. A lot of them. You can see the picture I see on Honey's book. You can see that on endoscopy. Page 92. You can see many diverticuli there on page 92. Okay, so if you look from the perspective of endoscopy, you will see as if there are holes within the intestine from inside out. The outpouching is from inside out, not from outside in.
Usually over 10. Usually over 10.
Oh, 7 ages, right? Yeah. Okay, now let's focus on this. Diverticulosis, the first thing you need to understand is, you know what I'm also going to try to do is, hopefully with next semester, so I'll be giving lectures, let's say, maybe 8 to 11, then you might have a break, 11 to 12, 12 to 3 or 4, you will have Shukrullah, and on different days, and then Dr. Masab practicing this with you, whatever I discuss. Okay, so I won't let you guys go home because we have to force you at least here to study. So hopefully this will benefit you to keep you here so you can actively learn. So how are those questions coming? Are you guys still making those questions about each section? No? Objectives? So do you guys make your own questions? For example, when you go home you want to study diverticulosis, what do? You should be at least writing a question. What is diverticulosis? Can you answer your own question? Today, tomorrow, next day, a year from now. And then what is the cause of diverticulosis? Can you answer that question on your own without reading? You know, that's the whole idea. That's what I'm saying. You have to be making these questions for yourself. I collected them once, but I'll randomly collect whenever I just want to make sure you're doing your job. So you should have them ready at all time. Okay? Alright, diverticulosis. So, at the end of the day, it's nothing more than outpouching of large intestine. Exactly. That's all. Diverticulosis is restricted to large intestine. It is not a disease of small intestine. Only colon. Only colon. Specifically, sigmoid colon. Sigmoid colon. Specifically, rectum and sigmoid colon. Okay? Now, of course, look, I can ask so many different questions. Once you understand the basis of it, you shouldn't have any difficulty. Alright. At the end of the day, if there is a wall of intestine that is outpouching, what do you think can cause that? What do you think?
Weakness in the wall.
Exactly. The underlying cause is weakness of intestinal wall.
Can we call it mini herniation?
It is herniation, yeah. But herniation, see, in a sense, is usually large. When it comes to large intestine, you don't use that term because these are so many little bubble, almost like pimples or what else would I say? Vesicles that from your skin. You know, when you have vesicles or pimples from your skin popping out, that's diverticulosis in colon. All right. So number one is if the underlying cause is wall weakness. It's weakness of intestinal wall. Then what can push it out? Pressure. There you go. What area of the intestine is under high pressure? Descending colon, because all the stool accumulates and it's stored there and it's going to push against the wall. Now, you don't even have to memorize it anymore. You answer your own question. Amazing. Why would you want to memorize once you know the facts? That the area of intestine that's under high pressure has to be rectum and sigmoid colon. It makes no other sense for any other place. Because again, at the end of rectum, what do we have? Sphincter. And that sphincter is usually closed. So imagine you keep pushing things out against it. Keep pushing things. Peristalsis pushes things where? From? All the way from small intestine all the way to anal sphincter. So where would they accumulate if you keep pushing it against the sphincter? Always in the rectum and sigmoid colon. Always. And that's the area under high pressure. This is the area that can dilate. That can expand. You know? Okay. So obviously the risk factors are, so weakness of wall. Now the risk factor is what? What would be the risk factor?
Cancer.
Age. Excellent. Let's focus on age. Most patients are over the age of 70. Most patients are over the age of 70. Why would age be a risk factor for such a thing?
Weakness in the muscle.
Wear and tear. Wear and tear. And what happens to repair as we age? Slows down. So now wear and tear will increase, repair will decrease. Obviously, those areas of the intestine that are under high pressure will be expanded. They will form diverticuli. Now, what skin is under high pressure? Yeah, skin. With age, what part of the body skin becomes more obvious? That you can tell immediately, oh, this person has aged. Face. Why? Because especially Hani, he's chewing gum. You're more at risk.
Really?
And Sam, yeah.
No?
The more you use, your oral muscle, the more.
So use your muscle detachment.
Yeah.
Smile.
Yeah.
I'm not gonna smile anymore. Grab
He's
this.
not gonna smile anymore.
Okay. Yeah. So when it comes to aging, wear and tear is a big issue. Big issue. So of course it depends on the genotype too. Those people who have big cheeks like me, they're more at risk of having these big folds. Those who don't, they don't. So at the end of the day, what I'm trying to tell you is wear and tear is a big issue. With what? With aging. And of course, wear and tear comes to what? Use. The more you use certain parts of the body, the more they'll get older faster. Compared to muscles and brain, the more you use them, the fresher they get. Completely opposite. Okay. Now, so age. Anything else?
Diet.
Diet. Excellent. Tell me, elaborate on this diet.
I mean low fiber.
Low fiber diet. So diet would be low fiber. What is fiber diet?
Cellulose.
Strawberries, banana, lettuce, celery, broccoli. There you go. All vegetables and fruit, especially fruit. They're high fiber diet. What's low fiber diet?
Meat. Fat.
Cheese. Meat is okay. It has fiber enough. Cheese, carbs, milk, sure.
Tea.
No, tea is good. Yeah. Let me have a sip.
Is it the same tea?
You know one thing about tea? It keeps you youthful. Yeah. If you can handle it though. Yeah. And it keeps your digestive system always.
Which one, green tea or black?
No, black tea is better. I prefer black tea, but so again, I'm not saying based on research so much. Research has proven that tea is good for you, but on practical levels, those areas where you have tea very common as a drink instead of alcohol, if tea is substituted for alcohol, and where they live actively, yeah, much better option. Much better option than milk, much better option than juices, than sodas, and much better option than also, you know what tea does? It keeps you alert most of the time. It suppresses depression. Yeah.
And it has caffeine. It has caffeine too.
Sugar? Chocolate?
Chocolate.
Chocolate.
In
Yeah,
the morning.
sure. Valentine's gone, my bro. Yeah, it has caffeine enough, but it's depending which tea you get. So there are some teas, as I said,
You need the lab.
you have to be
Ahmed tea is the
Long
best.
time ago. I need the lab for it.
yeah.
No, it's bad.
Can you imagine?
So low fiber diet is primarily fatty diet, American diet, Canadian diet, McDonald's diet, okay, fast food diet. That's low fiber diet. Now, why is that? Why would that put you at risk? Stool will not move faster. They're more likely to what? Accumulate. High fiber diet makes you to go faster. You won't store that food for a long time or stool. It lets you. Now, those of you who drink coffee and you don't drink coffee, do you see a difference in your bowel movement? Yeah, you do. Yeah. So caffeine tends to stimulate your bowels, increase motility, increase peristalsis. decrease absorption of water, just like a medication called
Low promid.
okay. which actually does which actually does the opposite, because it was supposed to give constipation. Okay.
Coffee, they tend to go to
That's
for more.
more.
Yeah, so coffee and tea are not only that, they're diuretics as well. They're diuretics. Okay? They're diuretics, so they keeps your urine and stool dilute, so you don't absorb more water. You absorb less. So you have to go in that sense. At the end of the day, it decreases your absorption time in period and content. So even if you eat fatty food, you have tea or coffee or something like that, you're less likely to absorb them, because the time in the intestine decreases and you're more likely to evacuate or excrete. Okay? But by far, tea is much better than coffee. That's proven. I would never go with coffee. I mean, it's personal choice too, right? Huh?
Caffeine is supposed to be good for cirrhosis.
For cirrhosis? Not really. I mean, cirrhosis, if you keep drinking alcohol and then at the same time you drink coffee, it's not going to compensate. Once you have cirrhosis, it's irreversible. Cirrhosis is irreversible. Sclerosis is irreversible. Gliosis, all these terms, when you say osis, they're irreversible. Okay? Irreversible. Irreversible. Cirrhosis especially. Once the liver goes through cirrhosis, you cannot reverse it. You can decrease the progression or slow the progression of it, but you cannot reverse it. It's there for life. Very difficult. As I said, exceptions do exist, extremely rare. For 99% of patients or people, they won't reverse. Yeah. Diverticulosis, no. Yeah. People don't live long enough. Usually becomes prominent in the age of 80s. When you're 80 years old, 70 years old, before they might... See, you can have diverticulosis but be asymptomatic. It could be asymptomatic. Yeah. Okay. Low fiber diet, meaning fatty diet, meaning a diet of modern world, so-called modern world, you know. So that's the diet we have to be careful. Yeah.
So in the case of somebody that's younger in their 20s, if they would have like a diverticulosis, are they able to reverse it with like a good diet? So they just have to be on a specific diet for the rest of their life?
It could decrease, and it can reversal it's very slow. So it might be there, but it's it's very, very slow. Once the intestine become weak. Now, young patients? So let's just put here. Let's say 40 years old. Do you think 40 years old can have diverticulosis?
Possible.
Yeah. So what should they have? What kind of conditions or abnormality should they already have to begin with?
Genetic sources.
For example,
Ehlers-Danlos.
Ehlers-Danlos or Marfan's. Excellent. Because they already have weak muscles, weak tissue. Okay, decreased elasticity, of course, and it has to always decrease elasticity. The more elastic tissue you have, the strengthened your walls are, or at least intestinal walls, right? So age, low fiber diet, of course, constipation. Now, what puts you at risk of constipation, guys? I'll come back to you. Fatty diet, low fiber diet, right?
Enough for medication.
Yeah, I mean medication. See, medication, unless you're on medication for life, when we talk about constipation, in this scenario is chronic constipation, not 1 day, not 2 days. Okay, chronic constipation. So patients who have decreased bowel movement, and they eat a lot. See, we have to be careful with that too. You can only use as a risk. Some people will have bowel movement once a week. Some people have it every day. Some people have twice a day. Okay, a person who has a bowel movement once a week and he eats less, absorb most of it, not a problem. But a person who eats a lot and he's constipated most of the time, or stool is always hard and he has bowel movement once a week, yeah, definitely they're at risk. At the end of the day, you have to imagine, as long as there's pressure against the wall of intestine, you are at risk of what? Diverticulosis. Whether it develops or not will depend on your genotype and your physiology, anatomy, and histology, which is unique for every human being. None of us look alike. What are the chances of our intestine being exactly the same? Impossible. So just the features, visible features. This is the anatomy. I don't like any of you. None of you look like me. Especially the girls, they don't look like me, right? So we look different. Our physiology is different. Our histology is different. Our anatomy is different. So yeah, some people are not at risk. Some people are at risk. At the end of the day, at age 7 and 80, almost 80% of the population is at risk of United States. Now, when we compare this to rural China, unlikely. Not like civil. I wouldn't say urban China. Urban China is the same thing because it's moving in the same direction. So, a lot has to do with lack of activities as well. Okay, so constipation, low fiber diet, age, and of course, female are more at risk. Why is that? Rabbi, can you please tell them, or just close the door? Female are also at risk because of lack of activity. No, nothing to do with estrogen. In this case, gender is a little bit not playing a role. It's lack of activity. It's lack of activity. Okay, lack of activity. Okay. All right. So of course, obesity. You know what? 3 things: smoking, alcohol, and obesity puts you at risk of every disease. Every disease, believe it or not. Okay. So, yeah, it puts you at risk of ischemia, yeah. Just to satisfy you. Okay, now, at the end of the day, what's the big deal? You know all of this. You know the risk factor. You know the underlying cause. You know what it is. So what's the big deal? Who cares? Do you care for diverticulosis? What could happen? What if I have 100 diverticula in my descending colon? Rupture. Excellent. Rupture, which will be called diverticulitis.
You can get stool stuck in there as it goes over time. You can get infection.
It causes pain as well.
Yes. Now, see, there's the thing. Initially, so let's think of this being colon, nice, straight. Now, I'm sure you guys are studying some anatomy, right? Colon has different segments. 1 segment, 2, 3. What do you call these? Haustra. Or think of it house, but it's not house, haustra. Haustra, haustra, right? So these areas, did I spell it correct? But these areas are segments, so that means this segment will contract together, and then when this contracts, this is relaxed, so stool will come from here to here, and then this will contract, and the stool will be pushed. It's all a segmental pushing of stool, so it doesn't go backward. It's like a worm. There you go. Excellent analogy. Just like a worm. Yeah. Yeah. Very good. Okay. Now, so here's the diverticulus. Diverticula is many. Diverticulus is 1. Diverticulosis, again, so many of them. Now, if this is a diverticulus, okay, so now stool keeps coming, especially due to constipation and solid stool, the fiber poor diet and so forth. Stool gets abstracted here. Now you keep pushing and pushing, and this stool gets eventually hard, and the more stools come and pushing. So eventually, what will do this? This will irritate this single diverticulum. It will irritate this single diverticulum. Imagine, rub your hand against your table, or just rub your 2 hands for 30 minutes. What happens? Just 2 fingers. Rub it for about 30 minutes. What would happen? Yeah, your skin will burn. Eventually, it will erode, and eventually the friction will continue, and you'll start bleeding. Now we're talking about, like, let's say 1 hour, 2 hours. Imagine 40 years, 60 years, 80 years this happens. Don't you think that these diverticular start eventually cause erosion and will go through erosion, and mucosa is gone, submucosa is gone, eventually blood vessels are exposed? Don't you think this would happen? Okay. Even if it doesn't go as far as muscularis or serocellar, Let's say it goes as far as mucosa, no big deal. It would be an ulcer sort of thing. If it goes beyond mucosa into submucosa, now we have issues.
Bleeding.
Yeah, nerves are exposed, bleeding. But usually it's painless bleeding, initial. Now the bleeding will be outside bleeding or inside bleeding? Internal bleeding, right? I mean, they're both internal bleeding. So is it intraluminal bleeding or abdominal bleeding? Yeah, the bleeding will be into the lumen, because we haven't got beyond muscularis and serosa. Okay. And this bleeding is painless. So whenever you think of diverticulosis, diverticulosis gives you painless bleeding, painless bleeding, painless bleeding. And it's common sense, obviously, because it hasn't gone to the level of nerves yet. So it's painless bleeding. Now, at the end of the day, the chief complaint, the underlying pathology of diverticulosis is what? Painless bleeding. That's your underlying, that's the major issue. Painless bleeding, painless bleeding. And who? And elderly people or patient. Now, if there's no bleeding, what do you think of diverticuli then? They're silent, asymptomatic, no big deal. In that, I mean, it's a big deal in the future, but it's there. Do you think you can discover diverticulosis on accident? Yes, most of them are. You do colonoscopy for something else. You know that people over the age of 50 are recommended, or over the age of 40 are recommended to do colonoscopy by American Society of Gastroenterologists regularly, every year. Okay, unless they changed it recently. Okay, so now, and you do colonoscopy, suddenly you see diverticuli. Yeah, it's there, but it's no bleeding, nothing yet. That's fine. So be aware that you can have asymptomatic silent diverticulosis. Okay, at the end of the day, symptomatic diverticulosis starts as painless bleeding. If it's painless bleeding, what would the patient be complaining of? Blood. Okay, they might not. So they might come complaining of what? Anemia, depending on the level of blood. Now, if it's fresh blood, that means there's a lot of bleeding, so you can see it. So you can have anemia, iron deficiency anemia. And anemia gives you the symptoms of what? Fatigue, pale skin, dizziness. Okay? Now, of course, there can be... Could there be melena? Yeah. Especially if it's slightly in the sigmoid colon higher up. And you have bowel movement, your bowel movement is every week, every 2 weeks. It's most likely melena or dark stool. But can you see hematochezia? Yeah, which is fresh blood. Melena, old dark stool or blood that has been in the GI for a day or 2 or 3, so that it was metabolized, it was changed. Old blood. Melena means old blood. Hematochezia, fresh blood, fresh blood, fresh blood. Make sense? Okay. That's all there is to it. That's all there is to it. Now, these are the first symptoms. But could it become worse? Yeah, and what is that? Perforation. What is perforation? Rupture, bursting, lysis, rupture. So these diverticuli, they can rupture. And let's burst one of them. I know those of you who are into traumatic medicine, you like these kind of things. You know, you want to have some excitement in your life, like, oh, I want to treat something crazy. I prefer patient having no problems. Now, when it ruptures, that means now what? Stool can leak into where? Peritoneum. Okay. Transverse colon is retroperitoneal. Sigmoid colon rectum is retroperitoneal. So you can have it retroperitoneal. Anyways, there will be leakage of things in the abdominal area. Okay. So stool. But obviously now it's bleeding too. There's bleeding. There's rupture. And this can lead to eventually inflammation of the what? Abdominal cavity, peritonitis. So perforation is bad because of what? Peritonitis. Okay. My charger. I think it's in the office. Yeah, please.
Do it like me.
Huh?
Do it like me. Charge it everywhere.
I leave it here.
No, I can't charge it everywhere.
Okay. Yeah, that's true. Yeah, that's one option. But I don't use this at home, so I just use it here. So I don't never take the charger. I think yesterday I took it to the office. Okay, can someone tell me what are the symptoms of peritonitis? Peritonitis is simply a complication of what? Diverticulitis, not diverticulosis. Diverticulitis, right? So, when it ruptures, it's called diverticulitis. Let me tell you that first. When diverticulosis ruptures, when there's perforation, then it's called diverticulitis.
What are you talking about, like inflammation point before it perforates? You should be able to catch it.
Yeah, usually it's the same thing as diverticulosis. So, yeah, possibly, yeah. But not common. Not common. Thank you. Thank you. Thank you. Okay, so now, please remember that now, usually diverticulitis occurs when there's perforation. Okay, before that it's unlikely, huh?
Perforation occurs because of
Diverticulosis.
Simultaneously. Okay. Perforation does not occur because of diverticulitis. Perforation can occur because of diverticulosis itself. But the likelihood of ruptured diverticuli to become inflamed and infected is very likely. Okay? Unlike unperforated one. They're not so much. Now, so when you have diverticulosis, this is the complication. Anemia, melena, and hematochezia. Now, diverticulitis will have peritonitis maybe, but they will have fever, pain. Where would this pain occur? Abdominal pain. Where exactly in the abdomen?
lower left quadrant.
Lower left quadrant, yes. Especially because sigmoid colon loops backward. Okay? Alright. Okay, so fever and pain. Whenever you have fever and pain, what are you gonna think? Diverticulitis. Diverticulitis. Okay, which is the same thing, yeah. So diverticulitis, when you have fever and pain, you're gonna think diverticulitis. If you have only painless bleeding and fatigue and so forth, you're gonna think of diverticulosis. Just to help you, but does it mean in real life you're gonna have these typical cases? No. Real life is real life. We're crazy people. We present differently. You know, people are able to suppress pain. People are able to suppress this. There's somebody's. Okay. Hi. How are you? I see you here today on time. Good for you. Yeah.
Would it cause intussusception if it ruptures?
Unlikely, no. Okay. Very good. So there you go. Now, would you be able to recognize diverticulosis and diverticulitis? Yeah, you should have no problem. Now, if there's fatigue and pain, you know, especially if there's fatigue and bleeding, always think of colorectal cancer, which means diverticulosis is a differential diagnosis of colorectal cancer or vice versa. If a patient comes, especially if a female comes, you need to write this down. If it's not in the differentials in your book, make sure you add them. Whenever an elderly female or male comes to you complaining of fatigue or bleeding, especially if it's silent, slow bleeding, weakness, lethargy, pale skin, What I'm saying at the end of the day, anytime a older female and male comes to you complaining of anemic symptoms and bleeding, you're going to think of few things. For female, you will think of diverticulosis. Now we're talking about over the age of 70, okay? Over the age of 70. Most of the time. Diverticulosis, colorectal cancer, and endometrial cancer. For men, the same thing without endometrial cancer because they don't have endometrium. Okay? So men will have, you'll think of what? Colorectal cancer. You will think of diverticulosis. And add to both of them angiodysplasia. So those four things you should always think about. Are we good? Okay. Now, what is the first step? What would you do first? Barium. When would you do barium? For which case? For diverticulosis or diverticulitis? For diverticulosis, the first step is barium. Excellent. For diverticulitis, barium is contraindicated. Don't ever do it. Don't ever do it. It's going to leak. It will spill into the peritoneum or abdominal cavity or pelvic cavity. You don't want to do that. Okay? So barium only, be careful, be aware. If there's pain and fever associated with this condition, you're going to think of diverticulitis. Don't do barium.
I would do colonoscopy first.
Mm-hmm.
Because I don't want to do barium. Take a risk,
Yeah. You can do colonoscopy if it is diverticulitis. Yeah, that's good. Okay. Even then you have to be careful. Why? Because you can cause even more damage. Yeah. So you have to be careful. But because colon is not as small as esophagus, it's large, especially with patient of diverticulosis, because obviously the risk factor is what? Constipation and pressure. That means the colon is dilated compared to an average human being. So you have a lot of room, to put a scope there and check it out without causing any perforation. Good. Okay. So number 1 for diverticulosis is barium, and number 1 for diverticulitis is what? Colonoscopy, or let's just say endoscopy. It doesn't matter. Colonoscopy, sigmoidoscopy will be the appropriate one. So depend what it is, right? Colonoscopy or sigmoidoscopy. Now, if the question tells you, what? The previous history is that there were diverticula in the sigmoid colon, you're going to prefer sigmoidoscopy, not entire colon. Okay?
Is it different?
Yeah. Sigmoidoscopy, let's start with the scopes. Anoscopy is only restricted to anal canal and rectum. And then sigmoidoscopy as far as sigmoid colon or descending colon. When you use the term colonoscopy, that means the entire colon you could check. So it's going further. Okay, more invasion, more discomfort, and you don't need to do unnecessary insertion of a scope if you don't have to. Okay.
Is it a different scope or is it just different procedures?
Yeah, the length is different. So you can have flexible and rigid. For anoscopy, you don't have to have flexible sigmoid scope because it doesn't have to bend and twist and all over the place. Yeah. Okay. Now, what would you do second for diverticulosis? What would you do second? Huh?
Check their blood if they have anemia.
Okay, you can do CBC. Excellent. And on CBC, what would you find?
Anemia, microcytic.
Microcytic hypochromic anemia. Excellent. That's the only anemia you will see. Microcytic hypochromic anemia, because it is what? Blood loss. On barium, what would you see? Outpouching of colon. So exactly what I drew on the right here. This is what you're gonna see. This. Okay. Number 3, what would you do? We're going too slow. Let's go faster. Colonoscopy. Okay, you'll do colonoscopy. Okay. Although barium is diagnosis, if you want to do further, you can do colonoscopy. Okay. Now, what is this? What is the management? What would you do in terms of management?
Diet change.
Absolutely. So they cannot have this rate of constipation forever. So they have to take what kind of diet? Fiber-rich diet, or high fiber diet. Very good. Okay. Huh?
Take more coffee.
I don't know if that would help. Okay. Yeah. Most likely motility, but motility of small intestine more than colon. Colon is really, especially sigmoid colon, those areas are relatively relaxed. Unless you feel the pressure of defecation, there's not much going on. Okay. Now, also if they're alcoholics and smokers, make sure they quit that as well. Okay. Other than that, and lose weight loss, so exercises. So these would help. All right. For diverticulitis, in addition to all of this, you will do what?
Surgery?
Okay, you can repair it, surgically repair, if it's bigger. You can also do one more thing, antibiotics. You have to do antibiotics. Because antibiotics, you have to get rid of that risk of, even if they don't have infection, give them antibiotics to prevent the risk of infection. And you might have to actually, in case if there's, depending on the size of the rupture, of course, if there's signs of peritonitis, you might have to do, not lavage, you might have to do laparoscopic surgery to evacuate and remove all the debris and stool and bacteria. Okay. Depending on the size. You can also do something else, if there's active bleeding, RBC scan. Okay. RBC scan. So you label the red blood cells, and when they leak out of that area, this will help you identify the exact site of bleeding. This will help you to identify the exact site of bleeding. So you can repair that area.
RBC scan.
Okay. That's diverticulosis and diverticulitis we're done with. Now, anal fissure. See, anal fissure is nothing more than a laceration, a cut, a tear. What's Mallory-wise?
Tear.
Tear where?
The mucosal membrane.
A mucosal membrane of which?
Esophagus.
There, you could be more accurate. What if I ask you mucosal tear somewhere else? Okay, it could be anywhere. Good. So now, anal fissure is a tear in the anal canal. Okay. It's a tear in the anal canal. Now, anal canal is one of the most superficial region of the entire GI tract. So when it bleeds, what kind of blood would you expect? Fresh, warm blood, actually. Fresh, red, warm blood. The patient will be complaining of bright red blood on tissue. So when they wipe, they will see bright red blood. Is it easier to see red color on white?
Yeah.
Oh my God, yeah. Yeah, so that's what they be complaining. Bright red blood on tissue. Now it's painful. It's painful. It's not like diverticulosis. Diverticulitis is painful. Diverticulosis, painless. Anal fissure, painful, very painful. Okay? It's superficial now. So again, what puts you at risk? Constipation. Constipation. Hard stool. Hard stool can cause erosion, irritation of anal canal. Okay? It rubs against the anal canal, which is very sensitive and delicate. Right? So obviously, that's the case. Also, no, not hemorrhoids. That's a different thing. I'm glad you reminded me. We'll talk about hemorrhoids. Also, homosexuals are at risk. Or I shouldn't say homosexual only. Anybody who performs or does anal intercourse. Anal intercourse puts you at risk. Okay? So anal intercourse, constipation, and of course, the skin of that area is, if it's dry, moist, lack of moisturization. So now there's patient who have, they're known as Jorgensen syndrome or Zika syndrome. They have less mucus production. And mucus gives you what? Lubrication. So less mucus production, especially in the anal canal area, puts you at risk as well. Okay. So it depends. Certain food, diet, lifestyle, all of those things. Anything that can decrease mucus production puts you at risk of anal fissure. Okay. And of course, you know, also when people use tissue and wipe, when they do it harsh, when they do it force, you know, that's why it's preferred. You know, I know you guys, because look, you're a physician. For physicians, there's no such thing as being grossed out. You know, your idea of helping people, relieving pain and suffering should supersede your cultural thinking and the idea of being grossed out and all of that. Right? Now, the preferred, what you're going to teach and what I'm going to tell you, it's up to you what you teach your patient. You guys might not become GI specialists, so who knows? You might not come across these patients, but nonetheless, you know, you should have some ideas. The best way to prevent anal fissure is what? Once you will advise the patient to use tissue 2 or 3 times, but delicately, softly, not harshly, and then wash with warm water after the patient has wiped. This should be the practice. Warm water. Now, cold water still, you know, if you have no warm water, go with cold water. You have to, at the end of the day, use water. Why water? Why is tissue not enough? From medical perspective, I'm not going to cultural issues, okay? You know, for example, let's say, and I will tell you this is reality. You can laugh at it if you wish. You know, this is where I come from. There were times in the early ages in our countries, tissue paper was only restricted to cities. We could not have tissue paper in rural areas. So what do we use? Soft. Rock is a wrong term. It's it's pebbles, you know, leaves, cloths, things like old clothing and stuff. We'll cut into small pieces, you know, whatever you could do. But there are rocks made of like soft clay, like sand sort of thing. But it will crumble if you push on it. Just helps you. And then after the water. So water is essential. You can use tissue paper. If you don't use water, what do you think could happen? Why scratch marks if you don't use water? What would water do? How does water help? I'm stressing on water for a reason. Huh? No, water can actually wash, you know. Don't use soap. One thing, don't use soap, okay? Water is good enough. Wash your hand with soap. Why? Hey, you sign up for this profession. You know, you cannot be disgusted by this. What is the best thing in life? Cleanliness, honestly. If human being cannot even keep themselves clean, I mean, seriously, what's the point of living? I would go that far. You have to be clean. Everybody has to be clean. To be clean, you have to use some methods. Even those methods might be disgusting, especially when I'm describing it. It might not be according to your taste and whatever. You know, people don't talk about it because they have this huge barrier between them, like as if they're robots. Each human being produces stool. That's the fact. Each human being defecates. That's the fact. You like it or you don't. Maybe Ahmad is unique, you know. Well, Ahmad told me, you know, that 200 years from now, he will eat food and it will just evaporate out of his body because he'll be living in an environment when you don't produce stool. That's what. And I agree with him. I want to be there too. Both of us will be there.
We will be there for sure.
I never said that.
That's in heaven. For sure.
I feel bad for you.
That's in heaven.
See, the thing is, I think your memory is... What's going on? Are you stressed? But anyhow, let me come back to why is water? See, water washes all the debris that's left, so you cannot always clean so good with tissue paper. See, rectum and anal canal has folds. You cannot clean 100%. So there will be some stool particles that will stay there. If you don't wash, water can easily wash it. If you don't, they will become hard. Not only that, I'm going a little bit further. You can close your eyes, but you're doctors. It's a great idea, not a great idea, it's an obligation of every human being, if there are hair, to cut them or shave them. Because hair does what? Traps, collects stool. And it dries up. Obviously, it dries up and becomes hard. And it causes irritation. So, water is essential. After each time a human being should defecate, use tissue first because you don't want to get your fingers dirty. Then wash with warm water, because in this country we have the luxury of warm water. But if you don't have warm water, go with cold water. But water is essential. It's essential. Okay? And make sure to tell the patient, wash your hands afterwards, because you don't want to transmit rotavirus or other bacteria to your children and so on else. Okay? So water is essential. So to prevent anal fissure, it can be prevented. The preventive measures are more important than treatment. Why even have the risk of this if you can prevent it, right? But anyhow, so again, who's at risk? Those patients who are mostly constipated. Those patients who eat fiber poor diet. Okay? So those patients who have hard stool. So if stool is sitting there for a whole week or 2 weeks, it becomes hard. Obviously, it's going to put you at risk of laceration and cuts and so forth. Especially when the patient is constipated and they push. I'm using the term patient. It shouldn't after they develop its patient, but before it's normal human being without being called patient. So forceful defecation and straining. And guess what? Straining also puts you at risk of what? What were we saying earlier? Hemorrhoid. Good job. Hemorrhoid. So you should not have to strain. You should not have to leave. You can do certain dietary habits to prevent all of that. Okay. So that's for anal fissure. Now, of course, once it's diagnosed, you can do endoscopy. You can actually see with your own eyes. If it's a little bit deeper, you can use a scope. In that case, it's not colonoscopy. There's no discomfort. The discomfort will be only social. People don't want their private parts to be seen, especially patients. They will not come to clinical attention. They don't want to come seek help. Usually people who don't come they have cultural issue, and as a result, they pay the price in terms of internal pain. They just deal with it. But the best solution is, again, prevent constipation, lifestyle modification, and of course, give them some lubrication. Okay, after each wash, they have to dry. Again, when you wash with water, there's another step I forgot. Once you wash with water, then you have to take some tissue to dry. Because you don't want to walk with moist anal canal. And the water can cause issue too. So it's a good idea to dry right after. Good idea. Okay?
Taking showers regularly prevents you have to go washing your hands. It's fantastic. Taking a shower.
Speak up.
Hopefully every day. So they're taking they take showers regularly.
Yeah.
When they need to wash after.
Yeah. So showers, okay, but there's the thing. My thing is, let's say a person takes showers 2 times a day. What's the person who will take shower the most? Who takes shower the most? Let's say, give me an example. 5 times, 6 times, 7 times? What's the maximum people take showers a day?
3 times.
3 times. 3 times the maximum. Now, yeah, 7 times. The thing is, the problem comes is that if you take shower right after defecation, it will resolve the issue. But if you give, how long does it take for stool to solidify? To become hard? Yeah, about like 30 minutes. So unless you, after defecation, or you save it until you go, I'm going to take shower at this time. Let's say people take 3 times a day shower, early in the morning, 12 noon, and then before go to bed. So if you reserve your stooling, your bowel habit to that, you just hold it, maybe it'll work. But the best way is, as soon as you go, if there's water available, go for it. But again, the thing is, the trend might even go that eventually, I think most of the public, toilets and stuff, the trend might happen eventually. And I believe it will happen. Not even might. Would it happen in our lifetime or sooner or later? Would happen that every toilet should have. Did you guys watch the show the cartoon? The Cars? You guys, I watched with my son. Yeah, Cars. Is it Cars? The second one. The second one, when he goes and gets trapped in that toilet supposedly in Japan, and so the instrument comes and it washes him right there. Eventually that's where we're leading anyways. Because preventive medicine will be the top medicine. Because why spend money on something if you can prevent it from even occurring? Yeah. So, but right now it's difficult, I understand. Yeah. Okay, so last thing, angiodysplasia, and then we'll go. See, angiodysplasia is a disease of elderly people. Yeah. Inflammatory bowel disease. If it's IBS, then it's, yeah. What are inflammatory bowel diseases? Crohn's, ulcerative colitis. Good job. Let's quickly do this and we'll take a break. Angiodysplasia. You see, angiodysplasia. What does angio mean to you? Blood vessels. What is dysplasia? Abnormal growth. See, in this case, what happens is the veins and arterioles communicate without capillaries. So look, just to kind of give you, those of you who have some ideas, that's good. If you don't, I'll quickly do this. The largest artery in the body is what? Aorta. And aorta will give you multiple small branches eventually, right? And these guys will become arterioles. So let's say this is artery, and then the next smaller one is arteriole. And then arteriole will give you many small branches, even smaller. They're known as capillaries. Okay. And then the capillaries will continue to become venous capillaries. So capillaries have two sides, red arterial and then venous capillary or venule capillary, and they'll combine to make venule. And then venules will become veins or vena cava in this case. Okay, so there's a communication between the venous side and arterial side. So of course the arteries will get smaller and smaller and smaller, and then veins will become larger and larger and larger until they drop where? Into the heart. So now in angiodysplasia there is direct communication, abnormal direct communication between arteriole and venule. With aging it occurs. Why? Because with aging the repair mechanism is defective. Capillaries are not formed, so there's miscommunication or so forth. Not everybody has it, but nonetheless people are at risk. People will develop this. Okay, so it's a true disease. Now in this case the issue here is the pressure can increase and these guys can rupture and cause bleeding. So angiodysplasia is nothing more than bleeding. Okay, it's nothing more than bleeding. That's all. Now angiodysplasia can occur in the brain, it can occur in the GI, it can occur in multiple parts of the body, but by far the most common locations are GI, skin, and brain. Okay, so GI and skin by far the most. Okay, Osler-Weber syndrome, for example, you will have angiodysplasia in the GI, and plus you will have skin ectasias. Okay, so they will have skin rash. Skin rash in this case will be made of blood vessels. You will see these blood vessels engorging and dilating, and you can see like this, like spiral, like snake, like dilated veins and venules and capillaries and so forth. But they will also have GI bleeding. Okay, at the end of the day, it's nothing more than bleeding. It's bleeding and elderly, and it's usually dark blood because of venous blood. Could be fresh. Most of the time, it's dark blood. Okay, and it's painless. It's painless. Whenever, write this down in big brackets or big square and star, whatever you believe in. Whenever somebody has bleeding whose cause you cannot determine, think of who? Angiodysplasia. Whenever somebody has GI bleeding, I shouldn't say not skin bleeding, GI bleeding. Whenever somebody has GI bleeding whose cause is difficult for you to indicate or come to conclusion, when you're confused and there's GI bleeding, you're going to think of angiodysplasia. Age is a big factor though. So bleeding in elderly whose cause is unknown, or you cannot pinpoint to something specific, you're going to think of angiodysplasia. Again, you'll do all the same tests as we did for diverticulosis to rule out a lot of things, because diverticulosis is by far more common. Cancers are more common than angiodysplasia, for example, colorectal cancer. Okay, so you have to rule out common things first. If nothing is working and you're like, oh my god, what's up, it's angiodysplasia. And then you will have to do RBC scan, and RBC scan will show you, angiography will show you that these vessels are dilated. Okay, and then the bleeding site will be identified too. You have to do surgery. The only solution is surgery, nothing else. Okay, let's take a break, and then we'll go to embryology right after this. Just hold on.
So, what time are you going to be
Did you do the same test yet?
No.
So do the same test. You have it emailed to you.
Yes.
Just do the same test.
But I have the answers. At least 1 to 13.
You memorized them?
No, but we went through up to 1 to 13.
Okay.
I think 16. I wrote them down. Well, I won't look at it.
Okay, so do your best. I'll focus on the 13th and on. But regardless, I give everybody 10 points. So it matches up. Okay. So just do the same exam. Yeah.
Is it have one there?
Huh?
Moneer finally.